Okay, well, hello everybody. It's great to be here. I'm David Prescott. I hope and trust that you can see me. And I have just gotten to the hotel where I'm going to be spending the next few days, and was really hoping that I could make it in time to present part 3 of this webinar. So anyhow, here we are, and away we go. This is an overview of juvenile risk assessment presented by Dr. Phil Rich. And today is Tuesday, May 24th, 2016, and so let's get right to it. Some things that you should know first. NERI Press, I've mentioned this in different ways in the past couple of weeks, but NERI Press has been publishing books since as long as I can remember, about 15 years, I believe, and has over time tried to seek out any way that it can help further people's education in this field as much as possible.
Hey, David, sorry to interrupt, David. This is just,
Sure.
I actually can't see you, so if you have your webcam on or your slides, we don't see either of those.
Okay. Can you see my slides? Can you see me?
I can see you now, yes.
Okay, can you see my slides?
No, I can't. Not yet.
Ooh. Okay, that's strange. I made myself the presenter. We don't need to spend too much time on this, I don't think, but how about now? Is this a little better?
Cannot see the slides, but I can see you. Tim, if you want to give me the control, I can show my slides and walk David through those.
And while we do all of this, folks, I'm just going to say that NERI has worked very hard to figure out how is it that their readership and their audience learns, and how can this be done? How can NERI go and make their learning the most effective that it can be? So is that my slides or yours, Joan? There we go. Well done. So without any further ado, let me just introduce you to today's learning objectives. Again, we're going to understand and be able to describe the juvenile sexual risk assessment process and the instruments involved. We're going to recognize the importance and process and contents of comprehensive juvenile risk assessment, something we spoke about quite a bit last week. And then we're going to understand how the risk assessment process serves as the foundation for treatment planning and case management. And you know, Joan, I'm just going to go off script. I know you have to step out. I'm going to go off script and just say, in addition to all of this learning, in addition to all of the great work that NERI Press does, is all of the folks, the sponsors that make these webinars happen. I will talk a little bit about them later on, but just want to put it out there for all agencies that I hope you'll consider becoming a sponsor. I know that my agency, the Beckett Family of Services, has done exactly that a few times. NERI does incredible stuff, and very often on the very thin margins that make up the kind of work that, frankly, we all do these days. I don't know anybody that's paid what they're worth, and I don't know any agencies that don't have to deal with budgetary issues from time to time, so please do consider being a sponsor. And so with that, here's our learning objectives. That's a little bit about NERI, and I believe it's just about time for us to turn this over to Dr. Phil Rich, who by now you are quite familiar with, a consultant and author, has been around for a very long time. Here's Phil now. Here's a trivia fact that I don't think you might know about Phil. He wrote his, was it your dissertation, Phil, on clinical supervision. Something that I noticed once, I forget how I came across that information, but Phil has written quite a bit on the process of clinical supervision. And you can actually read a chapter of his that was published in a book by NERI. So with that, Phil, thanks so much again for having me and for being here, and
yeah.
Take it away.
Okay, so I should be able to give, okay, can people, just someone let me know if you can see my screen right now.
Yep.
Okay, good. All right, so before I start, So this is the fourth, really, of the series. We've done one a week for the last 3 weeks, and we've really moved through this stuff pretty quickly. I'm going to take perhaps a little bit more time today, which means there'll be a little less time for discussion. I'm still going to try to get it done in 30 minutes, however. So here I'm going to try to condense an awful lot of information and use a case study. Some of you, I've used this particular case study before, although not in this way. So some of you may be familiar with it if you've sat through any of the trainings I've done where I've used this particular case study. Good one. So I'm going to walk through that. I'm sorry that there's not a way for you. You certainly will be able to get a handout of this whole thing, including the case study. I'm sorry you don't have one in hand right now. So obviously you're going to have to follow along as I go through this, and I'll do it a bullet point at a time. I'm going to describe this particular case, Daryl, 14-year-old. And at the end, I'm going to then look at how I scored 3 instruments. And of course, there's no time for discussion. This could be a whole morning thing if we were interactive. But it'll give us an overview only of those instruments. And then we'll talk a little bit about case formulation after that. What does it tell us? So it's a lot of stuff, but again, we plan to go a little bit longer today if necessary. So here's Daryl. High to high average, above average IQ. Every detail I put in here has meant to have some meaning. That's why I'm telling you that. So we know that he's high to high, above average IQ, grade level, no known learning disabilities, but he gets B's and C's, not an A student. He's had an IEP for a number of years, behavioral, emotional, social, average appearance, a little bit overweight, little short, height is acceptable, but on the poor side, unkempt. He actually sounds like me, especially then. Experiences between 2 and 12, so pretty much his whole life. Certainly did not provide a consistent or stable base for social development. You'll see that a little bit as we unfold this. At any point, and prior to that, there were lots of problems, which is what led to the divorce. Since the divorce, Daryl has just moved around over and over from one parent to another. When he lives with his mother, she moves, not infrequently, from naval base to naval base. And you add to that the fact that both of those parents have either remarried and or had multiple domestic partners since their divorce. So lots of people coming in and out of his life. From 2 on, shuttle between parents, never stayed anywhere for very long, typically 9 to 15 months, a couple of times, close to 2 years. By 5, behavioral problems, those continue through childhood. He never becomes somebody who is wildly out of control in terms of behavior. As you'll see, he's more at the oppositional end of conduct disorder. But those problems develop from about 5 on as he comes into school, starting at home prior to that time, then extending into school. Never severe. Again, mostly oppositional, moderately demanding, mild theft at home from peers in school, shoplifting, mild stuff, often in trouble at school, mild stuff, but petty theft, well, mild compared to what could be happening, I should say, but significant. Petty theft, not doing schoolwork, disrespect toward teachers, not a physically violent kid, but a kid who could be disrespectful. Few friends. When he did make friends, we can think of them more as school acquaintances or with other kids in his neighborhood, but they didn't last long. They didn't last long either because he moved away or they moved away from him. I don't mean that geographically. They became more distant. He was the kind of kid who, if he had friends, they didn't last for very long. Wasn't a kid who was invited to people's homes. Wasn't a kid who had people coming to his home. Early on, his parents saw him as a very demanding kid who could not be consoled, although important to say, we're giving you minimal info, his parents were not really able to console him, partly because of who they were, and of course that's important to note. Nevertheless, they saw him as inconsolable. Later, they saw him as a socially awkward kid who didn't fit in anywhere and didn't seem to care much about himself, and that being inconsolable shifted to a kid who didn't seem to show much emotion at all, seemed to be stoic a lot of the time. By 6, his parents are arguing about who should take care of him, who should have custody, except the argument is it's the other parent. I want you to take care of him. They both saw him as a difficult child. So this wasn't a tug-of-war kid. This was a push-a-war kid who can push the hardest. So lots of moves between parents, sometimes because of their living situation, sometimes because of problems that he was having at home, sometimes because there were new families that were coming in, new domestic relationships in which Daryl was sort of pushed out, never felt welcomed, and his parents, of course, not only did he move a lot, but they moved a lot. They became close to any of the step-parent figures or actual step-parents who just came in and out of his life, including their kids that they had, though. When the relationship ended, it ended. It was the end of the relationship. By 13, or at 13, he sexually abuses a 3- and 5-year-old sisters who are the mother's domestic partners, so they're living together. Repeated vaginal and anal penetration, so repeated and severe. He told the evaluator he didn't really like the kids, but he didn't really dislike them. He didn't really care much about them one way or another. No strong feelings of dislike. Didn't want to hurt them. He did acknowledge he sometimes got angry with them because he thought they got a lot of attention from their mother. But he said he never really cared about them, and he rarely interacted with them, and that was what his mother reported. Upon discovery, he's moved to his father's home. His father later drops Daryl off in court for a hearing and then leaves the state, literally leaves him in court, leaves the state with his new wife, third wife. Daryl, a little about Daryl, avid television watcher, moviegoer, video gamester, all things that could be to some degree social, but in his case were isolated and not social at all. These things, of course, are flooding the media that he's using. Sexual images are really underneath of almost everything. And as he gets older, he starts to look at pornography that's easily available online. By everything we can tell, looking at the hard drives, the pornography was age-appropriate pornography. In terms of also content, not just age. But he did acknowledge that he had some fetish material in a way he thought, in which he was in charge of the action. Sexual interest, we know that he had lots of other people in his life, lots of people, peers, older step siblings, babysitters, parents. So that means there were lots of opportunities for him to have been sexually victimized himself, or in some way to have been exposed inappropriately to sexual material. So we know that. But there were no reports really ever made of him being a possible sexual abuse victim. He never engaged in sexual behaviors that would draw attention to himself, so nobody saw him as precocious. So it never really came up. It is possible that he was sexually victimized, but the emergence of his sexually abusive behavior coincides with the emergence of both puberty and his use of pornography. Up until now, he's worked with a number of social workers, psychologists over the years, since about 6 or 7, several times been in outpatient treatment, but either never followed through or maybe attended a single session. Never really has had a diagnosis, never been treated for a psychiatric disorder, which doesn't mean he didn't need to be. There is a history of substance abuse in the family on the father's side, but in neither parent, specifically a mental health or substance abuse disorder that we knew of. A father totally out of the picture. A mother was involved at the time of this case. She's out of the state. She's really out of contact. Once in a while contacts him. So without knowing any more than this, we can see this is a kid who is, and I don't mean to put a value on being self-centered, but a kid whose focus is on himself. At home, and then later, as he develops in the school, in the community, which he's meeting his own needs, isn't thinking about other people. Probably driven by the fact that for his entire life, other people, including family members, they're not very long in his life. They're interchangeable. And so, in this hypothesis, he regulates himself. He does the sort of things that meet his needs rather than other people's needs or the needs of society or if you will, moral needs. He hasn't a relationship with his 2 stepsisters at that time. He imagines and expects that they're going to leave his life anyway, and he's got good reason to believe that. He probably feels distant and unaffected by relationships. As we do this evaluation, we're trying to get in all this information so we can do a risk assessment, or if we will, a risk assessment instrument as part of a larger assessment. So he may feel someone who's really unaffected by relationships, or avoidant, or at least distant in relationships in which he takes care of himself, he's dependent on himself, and he doesn't really think about the effects on other people, and possibly not even on himself. So that's the case. you'll be, again, I'm sorry you don't have it in front of you, but we'll walk through it and I'll remind you of key pieces as we go, and I'm going to come back to it after this. But now this will give us a chance to look at these three instruments, how I scored it. Some of you may be familiar with these instruments already. Some of you may not. You're familiar with them, and this will be an easier process. If you're not, I'm certainly going to be tuned into that. But I will be working from, not literally in front of you, but when I'm scoring this instrument, the eraser in this case, I'm going to be scoring it from the eraser, in a sense, workbook, if you will. The same is going to be true for the JSO and the other two, the other instrument that we'll use, because you have to know what each of these things really means when you're scoring them. We've got these 5 areas. So in this case, we've got a scale that looks at sexual interests, and each one of these is judged as present. These are intended to represent risk factors. Present, partially present, and I'll come back to that in a moment, or I don't know, not known. So not really is intended to represent not known. We don't know. And unknown represents we don't know. There's no other scoring system in this, but the eraser manual that the eraser is part of, it defines each of these terms. There's also an eraser, the Jim Worley, primary author, put out an eraser, in effect, case studies booklet that just tries to give examples. So there's certainly some, nothing's as good as training and supervision, but there's certainly resources out there that can help. So I'm going to walk through them quickly, knowing that I'm not going to take the time to really describe each of these things, because that's in the handbook. It would take too long. Deviant sexual interest, I scored as, no, not in Daryl's case, not that we knew of. Sexual arousal to children, for instance, even though he sexually abused children. Obsessive sexual interests, not that we know of. This wasn't a kid who seemed to be obsessive about sex. Wasn't spilling over. Attitudes that support sexual offending, not really. He didn't think it was the right thing to do. Didn't think it was okay to have sex with children, for instance. Unwilling to alter his deviant fantasies. No, he didn't have any deviant fantasies, socially deviant fantasies, but certainly he didn't think it was okay to have sex with kids. He wasn't sexually aroused by kids. At least there was no evidence of that. So this is just a quick look back at that. So I scored this as 4 not presence. Then we go to the second, in effect, scale. This is basically the history of the assaults. Assaulted 2 or more victims? Yes. Sexually assaulted the same victim 2 or more times? Yes. So a history so far looks much different, more severe. Prior adult sanctions, were he ever on probation? Had he ever been, in some ways, had an intervention based upon sexual assaults? No, he hadn't. Did he threaten or use weapons? No, didn't need to, actually. Sexually assaulted a child? Yes. There's no partials here so far. Sexually assaulted a stranger? No, they weren't strangers, and the eraser defines specifically what it means by stranger. Indiscriminate choice of victim, meaning were it boys and girls, young children and adolescents? No. One focus. Sexually assaulted a male victim? No. Diverse sexually assaulted behavior? He engaged in quite a few behaviors with those 2 girls. Psychological, so take a look back, I'm sorry. You can see there's a bunch of nuts, but there's also a bunch of what we might think of as high risk factors in there. His general functioning, antisocial, somewhat, not super, but you know, he's going to lie to you, he's not going to be honest with you, he doesn't really care for you, he doesn't feel that what's yours is yours and what's his is his. Again, only mildly or mildly, significantly oppositional at the mild end of conduct disorder. Lack of intimate peer relationships, you betcha. Negative peer relationships, not really. Interpersonal aggression, not really. Recent escalation, no. Poor self-regulation, somewhat, not terribly, but take a look at that. You see what you've got there. You've got some nuts and some partials and/or presence. Family environment, high stress, somewhat, but not super high, based upon the description in the eraser. These things are dynamic. They've taken place in the last few months. Problematic parent-offender relationship? Yes, definitely. Parents don't support treatment? We don't know. They're not involved. Reoffense opportunities in the environment. If you were back in the environment, excuse me, in the environment that he's in at this time or has been in the last few months, no. And then in terms of treatment, has he developed the risk relapse plan? No, he hasn't. And has he completed treatment, or at least a significant portion of treatment? No. So when I put all that together, excuse me, there's one other opportunity for people to add something that the eraser may not have caught. I didn't add anything, although there is actually stuff to add, but I wanted to make it pretty straightforward. So totals, there were 8, as I scored it, 8 present, 3 partial or possible, 13 not present, and 1 unknown. You lump them together, you wind up with present or partially present risk factors, things that we think are important in terms of the things that drive sexual recidivism, knowing that it's never one thing or even 2 things or even 3 things. It's the overall, it's how it comes together. So we'll come back to that. So partial or present, 11. So that shifts it a little bit, but not present, still or unknown at 17. So of these options, low, moderate, or high, I assessed them at moderate. I could have highlighted low and moderate and said, well, you know, it's somewhere in between those 2 things. But to keep it crisp and clean, I saw them as a moderate risk using the eraser. If we all had the same info about this kid, because it's much more than I presented, and we all use this instrument, we all ought to come out with the same rating. That would be called inter-rater reliability. We might be wrong in terms of our accuracy, but the instrument would be really consistent in helping people to score it. That's always a consideration, inter-rater reliability. Here's the JSO, same case. So scale 1, which is a static scale, it looks at history, and so it asks the question, and again, following strictly the JSO manual, which, by the way, always highlights the idea that you've got to follow the rules. It's got to be part of a larger evaluation. You cannot assess risk on the results of the JSO alone, which are numerical. You need to understand the case comprehensively, and it's useful to have 2 or more people working on a case together. You have a different sets of eyes and ears. So, based strictly on the scoring system, he gets 0. Prior legally charged sex offenses, there weren't any. Number of victims, he gets a 1. And again, it's based entirely on the scoring rules. Male child victim, no. Duration of sexual offense, based entirely on the scoring rules, he gets a 1. Degree of planning, 2. Some of these, nevertheless, like that one, it does require a clinical judgment, degree of planning. Sexualized aggression, meaning did he use aggression above and beyond what he might have had to do to get his way? And the answer was no, he didn't. In fact, he didn't use any aggression that we know of. Sexual drive and preoccupation, none that was obvious. This was not a guy who people saw as consumed with sex. Victimization history, not that we know of, doesn't mean he didn't have one. Sexual preoccupation scale total 4. We'll come back and look at how that's scored in a bit. Scale 2, also static, but it looks at non-sexual stuff. Consistency of caregivers definitely gets a 2 based on the scoring, but that's intuitively correct, right? Pervasively angry, somewhat, there's some anger in there that's been there his whole life. It's mild. School behavior problems? Yes, definitely. History of conduct before age 10? Yeah, wasn't super duper conduct disorder. Juvenile antisocial behavior since that time? Yeah, no. Other than the abusive behaviors, mild stuff. Charged or arrested before 16? No. And again, this is strictly following the rules. Multiple types of offenses? No. These are non-sexual. History of physical assault or exposure to family violence, some that we know of. I'm not sure the extent of it and not even sure really what happened. So on this scale, he gets an 8. That's just totaling it on. Then you go to the dynamic scales, what's happening right now, if you will. This is intervention. This is, in theory, how he's doing at this time in the evaluation and or treatment setting. Does he accept responsibility for offenses? No. No problem, excuse me, because he fully accepts it. So a score of 0, a score of 0, no problem. Internal motivation change? No, doesn't seem to be. Understands risk factors? Not really, no. Empathy? Well, it doesn't look like it. So suddenly we're seeing a very dynamic picture of this kid where, well, this stuff's going on right now, and we think these things contributed to the sexually abusive behavior. That's what we learned in gathering all this information. We were trying to plug a sense of who this kid is into this instrument rather than letting the instrument define who the kid is. Remorse, guilt, no, doesn't seem to be. Cognitive distortions, things that drive his thinking, behaviors, attitudes, somewhat, not super duper, but yeah, definitely something we want to pay attention to. These become targets for treatment. Quality of peer relationship, 2. Again, basing it really on the scoring rules, but now suddenly comes up with a relatively high score compared to those other scores, 11. Now, this final scale, we can't score for somebody who's in a residential program, who's out of the community or incarcerated. So, because he was he gets, he doesn't get anything. They're zeros. This doesn't get counted into the final score. You look at the overall, and what you do is in that first scale, you take the total number that was scored, that was a 4, and you divide it by 16, which is the maximum number of points, and you get a 0.25. And very briefly, what that means is that of the 100% of the risk factors you could have present, you have 25% of them. That makes sense? Doesn't mean you're at 25% risk. On the impulsive scale, this is the non-sexual, he's got 50% of the risk factors that he could have. He's got 50%. That's not obviously the worst thing, but it's certainly not particularly good. Dynamic scales, the kind of stuff, let's call it 0.8. 80% of those risk factors seem to apply to him in terms of his current interactions, what he's learning, who he is now, and we couldn't score the community scale. So then we add those up, following the rules, but say they're static. It's these two added up, and we see that the history, let's call it 40%. 40% of the risk factors that might point us towards a significant history, 40% of those he has. So we might think, well, okay, that's moderate, but when we look at the dynamic scale, and you can see I've crossed it out because we've only used scale 3. We can't use scale 4, so the rules change a little bit. Unfortunately, the JSOAP manual doesn't make that really clear, but this is the case. So that winds up being, relatively speaking, high, right? 80% of the potential risk factors. Doesn't mean there's an 80% chance to reoffend. When they're all added up together following the rules, he comes in at about 0.50. My own guidelines, absolutely, JSOAP says you cannot use this to assess risk, and I agree with all of the instruments having that same standard. It's part of a comprehensive assessment, but when you do just a down and dirty one, when you want to see where that falls, it falls into the moderate range. And certainly the static factors fall really into the low to moderate range, but despite the significant sexual behavioral problems, it's the dynamic risk factors that fall into the high range, looking at that scale. And here's the JSOAP, which I'll go through pretty quickly. The JSOAP, if you remember, is unlike the eraser and the JSOAP, which we talked about as a refresher, they're the two most common instruments. Yes?
Hey, Phil, sorry to interrupt, but it seemed like a good time. I did see a question from Anne saying, could you quickly review why you chose moderate over low on the eraser? It was pretty clear on the JSOAP.
Okay, let me go back to that.
Sure.
I'm just going, but you should see me going back through time here, right?
Oh, yeah.
Yeah, I got to do it.
How many of us have time to do this?
Okay. Okay, well, look, that's I think it's not only a fair question. I think it's a really important question because the JSOAP that we just looked at avoids the question totally because that little down and dirty scale I gave you is just my down and dirty scale. Helps me to put it into a context. The JSOAP doesn't give any such scale and says you can't use the number to determine risk. And so even though it gives you a number that you arrive at in a very concrete way. There's no clinical judgment involved. You follow the scoring rules. If the scoring rule says 2, you get a 2. You can't change it, and the manual was really clear about that. But because it doesn't yield, that score doesn't yield any meaning, and that's the JSOAP very clear in saying that you assign meaning to it, even though the process of assigning a number is really non-clinical. The process of assigning risk is clinical. So you might take those numbers that we came up with and say, for Darren, and say, look, you know, given all the other things I know about him, I think he's at low risk. So in either of these cases, there's a level of clinical judgment. It just depends on where it comes in. In the case of the eraser, it's there the entire time. Not in every case. Some of the risk factors are clear enough that they guide clear enough in structures there's no clinical judgment involved. But at the end of the day, you're making a clinical judgment. So of these 3 choices, I think that is, you know, when I look and I see, look, this guy's got, you know, 11 risk factors or partial or present risk factors out of 25. That doesn't mean he's going to reoffend, but I don't think that's low. He's got a bunch of not presents, but those 11 count for something. And in fact, the eraser, like all of the clinical instruments, tell us that we can weight factors, so clinically weight factors. So I may think, well, you know, even though there was only 1 offense, it was a really, really serious offense. Obviously, that wasn't the case in this particular case study. And I may feel like that that particular incident, because of the severity or the nature of it or something like that, I may think it's of much higher risk than I normally would, and I would weigh it against these other risk factors. So at every point in the eraser, there's a clinical judgment, and the clinical judgment is always, that's the target really of criticism, clinical judgment. But studies have really, I think the ones that I know of, have support clinical judgment only in the context of having a lot of information. You don't have a lot of information, clinical judgment's not worth anything really. It's not worth much. But in a rich informational environment where you know a lot, which is the point of a comprehensive assessment, you're feeding that judgment into estimates of what might happen, making some form of judgment. So all of that is my way of saying I didn't want to weigh the presence of a risk factor against the absence of a risk factor as somehow neutralizing one another. I think 11 is to me, it denotes that he carries a moderate risk level because he carries a moderate number of risk factors in his life. So even if it numerically doesn't add up to somewhere right in the middle, it'll be a little higher than that, I'm giving it weight. So I hope that makes sense, and I hope that was a decent explanation of the similarities and the differences between these two particular instruments, which are the two most commonly used instruments. So,
and Phil, if I could, just one more small question from John. Wouldn't the parents be considered not supportive if they are not staying involved in the treatment regardless of their location? I don't know. You remember I said at the beginning of this case study, I've actually never used the case study in this way before. So I didn't think it through in the most, and I don't mean that in a dismissive way, I didn't think it through in the way that I might in the real world. I thought about it really just from the perspective of a case study, but that's exactly the stuff that case studies should do, what generate questions. Yes, you can see I'm lost for words. Yes. We could say that the parent's complete lack of involvement in his life means that they don't support any kind of treatment. I would think of it more in the sense that when parents have died, they're no longer in someone's life, or they've been gone in no contact for 8 years. That's not true for his mom, but it's sort of true. It's certainly true for his father for quite a while. So I was thinking of them more as those relationships. They have no effect on his life. So it's not that there's not supportive treatment, they're not supportive of him and everything that goes with him. So you could, I'm not being facetious, you could argue they're not supportive of the way he dresses. They're not supportive of him in any way. They don't care whether he gets treatment or not. So I'd have to think about, gee, in his case, even if what I just said is true, in his case, does it still act upon him? Even maybe it's been 8 years, which it hasn't, but let's say it had been. Maybe it's still acting upon him. But that's not really the intention of it. I'm sorry, I'm thinking out loud there a little bit. The intention is really to talk about the active involvement of the parents. And in this case, it's really an absentee family. But, you could absolutely, put it as a definitely not. Read the instruction. If you were doing this case, that's what I would be doing. Right now, I'd be going back to read the instruction. I may or may not agree with the instruction, but I'm bound by the instruction. So we're not there to fudge the instructions. We're there to follow them. So I hope that makes sense. And that's another good question. And I hope it explains my thinking a little bit. But do remember, this is just a case study. I left out a lot of info, and I certainly wouldn't do it that way. I recognize that I have a limited amount of time. So. Nice. And I went immediately to, I would just like a little bit more information if at all possible. For all we know, maybe the absentee parents once a year say something like, yep, you go do that treatment and you go climb that mountain and everything will be good. Or something, uninvolved and meaningless like that. So that's it for me. But there were a couple of clarifying questions that I thought would be good for right now, Phil. So thanks very much for letting me interrupt.
Okay. Well, so let's look at the JSO. So those two instruments are clinical instruments. The JSO rat is not a clinical instrument. It's purely going by the rules. You don't need to meet with the kid. It should all be in the kid's record. This is how I score them, and I follow them exactly by the coding instructions. So there's no clinical judgment involved. Although in a couple of areas there might be a little bit, but in this case, he gets 1 point for his actual number of adjudications. He gets 1 point. Out of a potential 3, it's different on different questions. Number of victims, 1 point. Length of the history, 2 points. It went on for a while. Was he under supervision of any kind of probation? He wasn't, so no points. Was it a felony level offense committed in public? Nope. Did he use deception? Maybe a little bit. Prior treatment? Nope. Number of incidents and hands-on offenses in which he was the victim? None that we know of. Doesn't mean it didn't happen. And the same here with physical abuse, with the victim of physical abuse. No. Again, this is a statistically developed instrument. So this is an actuarial instrument rather than a clinical instrument. And this is what the particular research for this instrument drew as the 12 static risk factors. So you can see sexual offense victim or physical abuse victim. Not in his case that we know of. Any placement of special aid? Yes, yes. But gets a 2 or 1 based on the scoring. Number of educational time periods with discipline problems, he's had a lot. So he gets the full number there. And number of adjudications for non-sexual offenses, 0. So he winds up rank 8. Now this instrument is only normed and valid for use, I've mentioned this before, in Georgia and California where it's being validated. And in fact, if you're doing a risk assessment of a juvenile who's adjudicated, or in the juvenile justice system in California, you must use this instrument. And it's been validated for use in Iowa and Utah. Anywhere else, the authors have sort of relaxed their stand a little bit and said, well, you can use it, but you have to be really clear. You cannot base risk on this. It can help you to look at other risk instruments, perhaps, or to look at the case overall. But they're not valid instruments in these states because they're statistical instruments. But here's how that score looks. If you were in Iowa, these are the risk levels. Anything above 7 would put him at risk level 3. Okay, does that mean high risk? It's risk level 3. It's the highest risk level of the risk level. So he'd be in a higher risk level based on his static risk factors. Not who he is today or what we think might happen, but based on who he is now. And in California, Utah, he'd score in the 8 to 11 range. So he would score as moderately high. There's no high range. They actually have found that the recidivism rate is low enough. I think they're very reluctant to suggest there's any such thing as high risk. At any rate, he would score in the highest range here also, which they call moderate high. So that's a little tougher. That's a little harsher based on his history of who he is. In terms of static risk factors, the most relevant risk factors, his history of multiple and significant sexually abusive behavior. This is, again, historical. Multiple victims, big age difference, opportunistic, his own history of family instability, his general social instability, his lack of intimacy or belonging to anyone or anything or anywhere, consistent history of non-sexual behavior problems, although mild, significant history of adverse childhood experiences, even if he didn't get physically abused or sexually abused, and he may have done. But even aside from that, just the multiple moves alone, just the way his parents thought and treated him in terms of shuttling him back and forth. Dynamic risk factors, the things that we're going to really think about in treatment, disconnection, social isolation, weak social skills. Does he feel social loneliness? If he does, he's got it kind of tucked all the way down here, but he may feel socially lonely. Poor family relationships, lack of family support, lack of social support, negative view of other people, weak self-expression, even though he's a bright kid, lacks commitment to what we think of as moral norms or values, not motivated, doesn't seem to care much about other people, doesn't have a strong sense of remorse, doesn't seem to understand or care about the risk factors or the circumstances that led to the problem, and he's self-centered. I don't mean that in a possible way, but that's who he thinks about. And of course, he lacks trust in other people. All of these things become targets for treatment. Can you do one of them? Probably not, at least not at the same time, but these become treatment targets because they're active. If we look at protective factors, looking at the DASH 13, which is an instrument that looks at protecting, not a well-developed instrument, but a nice instrument nevertheless. And by not well-developed, I mean there's just not a, there is research, but there's no research about the particular instrument or what went into it. So this is developed by Jim Whirling, who's the co-primary author of the array set. So although it's not really a companion instrument, you've got the same author in both cases. So good addition to any kind. It's certainly not the only protective factor scale out there, but it's a good addition. It's available on the internet. Pro-social sexual interest. It doesn't give a lot of choice. It gives descriptions. The unknown, certainly in terms of what he says, he's saying the right thing. sex between adults, sex between same-age peers, sex between consensual peers? Does he seem to have pro-social sexual attitudes? Yes. Is he in a pro-social sexual environment at this time? Yes. Is he awareness of the consequences? Yes. Compassion for others? No. Positive problem-solving skills? No. Positive affect regulation? Yeah. He doesn't get angry, doesn't get sad, doesn't yell, doesn't cry, doesn't get depressed. Emotional intimacy with peers? No. Close relationship with a positive adult? No. Adequate environmental controls where he is now? Yes. Actively involved in pro-social activities? No, not unless he has to be. Does he have a sense of hope? Not that he expresses. So if you look at that, excuse me, successful treatment, as you know, but that goes without saying as he's beginning a treatment. What does he get? He gets 6 protective factors out of a possible 13. Those are things to build on, right? And of the no's, those are things to try to build into the way he thinks and the way he experiences the world. So it gives us, again, something to base treatment upon. Formulation of the case, taking a little bit longer. Partly because we went into the question and answer period, which, by the way, I think was a great idea. But that ate into it a little bit. Let me move a little bit more quickly. Thinking back to developmental path, I think we can imagine that these early interactions with everybody's relationships shaped the relationship he was going to have with those 2 kids long before they ever came into his life. That his prior experiences primed him for all future relationships, including his treatment relationships. We want to be aware of that. His assumptions about the world. We can also, I think, reasonably hypothesize that as long as he can remember, literally, relationships don't last long, and they don't feel particularly good, and that people who care or should care about you, they don't actually care about you. Nobody cares about you. And when he sees all these other people moving in and out of his parents' lives, nobody cares about anybody. Relationships, remember, end. Nobody seems to be, hanging on to them. Disconnected, not strong social skills in terms of relationships, self-regulation, doesn't care about other people, never learned to care about other people or think about other people's experiences or their expectations or their needs. And he doesn't worry about rejection because, why would he? That's his entire experience, literally. As long as he can remember, he's come to expect he will be abandoned, he'll be moved around. That distance from himself, think about it as an adaptation to the environment that he grew up in. So it's a developmental piece that we need to be aware of, rather than something that's about him, the demon scene. It's about the environment. It's about him in his environment, and the interaction, so we can understand, in his case, the weak development of social attachments and the cognitive schema patterns that come out as a result of that develop. Those are adaptations to that environment. And we know in his life, unless we think his life was great before he was 2 and everything was great at home, from the day he was born into an adverse experience. We also see that he was inconsolable at first by parents who weren't able to console him. But later he became stoic. So he distanced himself. He shut that part of himself down because it was painful. Don't think of him as unattached in terms of this formulation, trying to understand the case, but thinking of him for me, he needs to be connected, but it's a detached form of attachment. It's a distant or a fearful or an avoidant form of attachment in which he doesn't have much confidence in the people who are meant to take care of you, or as he gets older, his peers, other people. And he not only expects rejection, but he predicts it's going to happen. So this is a kid on the edges of relationships. He's numb to the relationships, and of course that's true of the 2 young children that he was a step-brother to. So we can understand his experience, and we recognize that he doesn't know what it's like to be cared for. He doesn't know what it's like to care for other people, and he hasn't developed that capacity to see into the minds of other people, see into his own mind, metacognition, being self and other reflective, even though he's an above average IQ kid. Poor family relationships, very weak, so it's no surprise that he doesn't experience anybody caring for him, or he doesn't care for anybody else. So no surprise there. So we can understand he wasn't connected to those 2 kids. He said that himself. They were just instruments. He didn't see them as people who needed to be taken care of or nurture. His sense of empathy for everybody is, let's just call it arrested. And let's call his sense of moral reasoning as arrested, rather than it can't move on from there, because the whole goal is rehabilitation and change and growth, and we believe that people can change, especially kids. So we can think, though, his moral development is arrested at a young age, a 7-year-old age, where it's pretty much determined by you're going to get caught. What's the consequences? And he's learned not to worry too much about consequences. His sexually abusive behavior, Okay, he's had a really bad life. That's horrible. Lots of kids have, but how did that translate into sexually abusive behavior? He may have been sexually victimized, but the emergence of the sexual abusive behavior happened at the time of his puberty and his pornography watching, driven by these messages coming in from all over the place, and add to that a complete lack of social and or sexual outlets. Let's just call them socio-sexual outlets. No relationships with anybody, no close family relationships, no opportunities to engage in any kind of test out any kind of an isolated kid, no opportunity to test out any sexualized interactions. And he actually looks a lot like, based on the description I'm giving you, this formulation, the kid that's often described in the literature, most typically described, the kid who sexually abuses somebody younger than himself or herself. Most of our literature, almost all of it, is about the himselves. And that's certainly true in his case. He obviously sexually abused children. You couple that with a distant sense of attachment from everybody, including not just immediate family members, but those sort of pseudo-family members. Take it where you can get it. You see that over the course of his lifetime. Disregard for rules, you see that over his lifetime, typically in school. Occasional anger they would feel, lack of connection to either sister. We can see that sexually abusive behavior is connected to, indirectly connected, but nevertheless fueled by that weak sense of connecting to anybody else, any kind of an attachment. He stays on the edges of relationships, but he goes towards those things that meet his needs to allow him to take care of his life, charge of his life. Sexually abuses his sister, he learns about sex. He meets these sexual needs, not unusual for somebody his age, in fact, common. Maybe a sense of mastery over the world, having a very different experience in relationships in which he's in charge, and maybe even fulfilling a little bit of that fantasy that he had of being socially competent. So I think we see a trail from these early negative experiences to just an arrested development of these really important social skills. These become targets of treatment, mild infractions but persistent over the course of the years, disconnection from other people, and as he comes into puberty, an interest in sex but no possible outlet for him. All these things came together because suddenly these two young kids came into his life easily within his grasp. Shifting that to treatment, I've got to say this quickly. This just says, look, assessment's got to be comprehensive. I said it during the course of the webinar today. It's just part of a larger instrument. Again, all the handout with all this material on it is available. So we see risk assessment about needs, not just risk. That fits very well with risk, need, and responsivity, which we talked about briefly. The RNR model fits with it perfectly well. Understanding it's not just about estimating risk, but how do you treat risk? How do you buffer adolescents against risk? Recognizing that means that assessing risk alone, it doesn't tell you anything. It just says somebody may or may not be at a high or a low level of risk to re-engage in an offense. And the reality is our risk assessment instruments aren't good enough to really give more than a good guesstimate. It's difficult to assess future behavior. So our instruments are most useful for case management and planning and helping us to see the risk factors and be able to count them, if you will. And so the focus shifts away from just prediction, as Villion and colleagues said. It's about helping to manage risk, plan treatment, getting beyond just the attempt to predict risk, but to really understand the case to prevent reoffense. That becomes the goal. Here's Prentke, right hand. These are the JSOAP folks. Risk assessment instruments are not predictive instruments that we can make long-term decisions on, but they're going to be useful to helping us to figure out what it is that we should be doing. Here's Benjes, Prescott, and Tafashik. We've got David Prescott, Joan Tablashnik with us. Steve Benjes, we've mentioned before, and many of you know, very sadly passed away not very long ago. A friend to all of us. David and Joan worked closely with him. As I wrote, I think in this it was the NERI newsletter, a great resource, easily available at the NERI training site. They say, look, the use of these instruments to really plan treatment, and that's what they mean by these risk assessment measures. That's a better way to go than just simply making statements about risk, high risk, low risk, etc. Wrapping up. It tells us, it points to the kind of risk factors that are the targets for treatment. They're not certain predictors by any means. That's an overstatement. But they do help us to think about targets for treatment. And so if we see lots of risk factors, does it mean that person's going to reoffend? Maybe, probably not. based on the statistics, but it does tell us there's a lot of risk factors in his life that need attention if they're dynamic. So it points to treatment, and it fits with the model of risk, but especially need and responsivity. So these things become targeted treatment. Initially, we're looking at the static risk factors. There's nothing we can do about it, but they add something to the to assessments of future potential behavior. We're looking at the dynamic risk factors, and we're looking for protective risk factors. Ongoing treatment, we're using risk assessment because we're going to be repeating risk assessment maybe every 6 months, maybe every year, but certainly somewhere in that range. What were the dynamic risk factors that were present at that time? And that's what we're working on. And are we strengthening or building new protective factors? And then when we reassess over time, what's the current strength of the risk factors now compared to how they were then? How angry is he now versus how angry was he then? What's the strength of the current protective factors? So it's much more about understanding the kid, the youth, the young person, so that we can build well-informed decisions around treatment interventions, around case management strategies. So we're not just looking to estimate risk, we're trying to really prevent risk. Okay, we've got 10 minutes.
All right.
The reference is attached. Okay, I will, I guess Tim will take off control of my screen and give it back to David. And I'll leave my mic and camera on.
Phil, there's nothing like listening to you say, I think I'd better speed this up a little bit.
Okay.
Since you're a pretty rapid-fire presenter as it is. So I am going to scroll down to a few of these slides here, and we're up into the Q&A. And Tim, I know you're going to interrupt me if for some reason you can't see my screen all that well, but here goes. So Phil, you had a great question. Are we good? Okay, thank you. You got another great question from Anne, who asks, how would you avoid blaming parents in understanding Daryl in writing your hypothesis in the assessment report, particularly if you end up treating Daryl and or his family? So this is an interactional quagmire. What say you?
Well, there's different parts to that question, I think. So I might get a refresher in a second. But the first part, how to avoid blaming them, they're not to blame. I mean, they're to blame for the environment they created. They're not to blame for the fact that their son, killed 20 people. I think, to use those horrible examples. So I think that they're part of our understanding what happened, and they may be part of our understanding what can we do to change that if they're still active in the kid's life. But that point is really well made, because if they're going to be clients, which I think takes that last part, we definitely can't blame them. I mean, why would they go into treatment if you're going to blame me? We're going to follow a family therapy model when we go into treatment. We're going to understand we're treating the family, and everybody in the family is our client. And just as it would be crazy therapeutically to blame our individual young person client for, you did this and it's, your problem, and so we're not going to do it with the family either. So we're going to build a relationship, and whether or not we get into a treatment relationship with them, maybe we don't, we should act as though we are going to get in a treatment relationship with them, that we're going to give them every contact we have, I hope, the most professional view of a caring world, a world that isn't blaming them, but wants to understand, so that we can all put it together, and that assumes that those parents do not want their kid to wind up in jail. They don't want their kid to rape somebody, no matter what they've done, no matter who they are. And there may be, there may be the odd exception. I've met a couple of them, but they're very, very rare, and they're kind of crazy people. So did I catch the whole question, David? And to it?
Yeah, I think so. How would you avoid blaming parents? And I guess I'll add my spin on it, which I think Anne might also be asking, which is, what ideas do you have about engaging these kinds of families that I think we've all seen, that are chronically difficult to engage, moderately defensive, and might respond to a lot of your questions by saying things like, no, we already tried that with our kid and it didn't work, or those kinds of. Am I making sense, Phil? How do you get families involved? By by fitting your style with their style. So
So if they're really on that end of it, you know, or even more, like, look, I don't have time. Can I call you next week? Or okay, I forgot. I know we've made a time, but I forgot to. Then I hate to put it this way, but you know, you try to kind of reel it in. You know, you try to put something out there that they can connect with, and to use the other extreme, because these parents also exist who want to. There's no such thing as over-involved. They are their kids, but they're not really willing to trust the providers, you know, so they're very, very involved, and they can drive providers insane. You know, they're calling every day, they're challenging but that would be the other extreme, right? Those are the two extremes. So I think that you find a way for the parents who are uninvolved to connect with them, make jokes, you know, whatever it is they want. And in the end, you may not be able to get very far. You may say, is it okay if I give you a call again, you know, to get permission from them to continue. And for those are the distant parents. And the parents who are over-involved, to say, it's great, this is fantastic, let's talk, you've got to build a relationship with them, and the families in between. So I think you're building the relationship, you're trying to find ways to connect with them on every level. And I think that it's exactly the same stuff that we kind of preach about how we should be treating with our individual clients is exactly the same. It's non-judgmental, you know, it's accepting, it's unconditional positive regard. And I mean it. I'm not just saying it. It's the rules of therapy, you know, good therapy, you know. And you can't win everybody. It's some people, because we also have the common factors model. We say there's a whole bunch of extra therapeutic. They may just hate therapists, no matter what I do. You know, maybe I'm the wrong race, the wrong religion, the wrong ethnicity, the wrong gender. You know, I mean, there could be 1,000 things that have nothing to do with me. My job is to try to overcome that. All right. Sorry.
Nice. We have shared a few cases, haven't we, Phil? No, I'm just teasing you based on that last part. You know, Phil, I don't know if you remember a psychologist. I don't know if he's still active, named Bill Ballantyne in Vermont and New Hampshire. And I remember reading one of his reports, and he put it wonderfully. He said, "Look, let's be done blaming this kid as early as we can. Let's never blame the parents. If we're going to get angry at anything, let's get angry at the abuse itself." And I always thought that was a sort of nice way of separating what needs to be done from the you know, pointing of fingers and placing of blame. So I couldn't just resist working that one in there as well. Phil, we're almost at time. I wonder what other kinds of things you would like to say. Anything you thought of as you were speaking but didn't get to say?
Yeah, but we only have a couple of minutes. We thought about it ahead of time, because the last couple of weeks we thought, well, maybe I should take a little bit more time, but we didn't kind of. So I thought about, wonder what kind of questions that people might ask. So I gave it that thought ahead of time, just thinking about, well, what would I ask? But I think the questions that were asked were really good questions. They were more than good.
Yeah,
questions. They were thoughtful.
Those were really good questions.
Yeah. So thanks.
Yeah. I might just add a couple of things. One thing that interested me in the case is that this is a kid who, for whatever reason, just hasn't been willing to rack up a serious criminal record. For all of his disregard for others, he just doesn't seem that interested in going out and really overtly, you know, breaking the law with the kind of criminal zeal that that some people do. And then, you know, something else I thought about, and maybe you can say something about it in a few seconds, but I noticed he seems to spend a lot of time focusing on threats around, perhaps he spends a lot of time focusing on threats around him rather than attending to his own experience or the experience of others, and that might help explain his lack of concern.
Yeah, that's a well, that's a good way to put it. You know,
yeah,
it's a really good way to put it. I sort of hadn't thought of it that way, but that's a nice way to think of it.
Oh, thanks.
Yeah.
I thought we might be coming from more or less the same place there. So, really quickly, we also got a question about getting the slides up. There was handouts. I know that the behind-the-scenes team was working feverishly on making sure that we've got all the handouts. You'll also be getting various notices on how to access these videos and the other kinds of things. So this will be an interactive process between you and Neri. I believe, go ahead, Phil.
So last year I did for Neri a 3-day risk assessment training. I'm going to do that again in, actually I can't remember, it's October or November.
Yeah,
so,
October 17th through the 19th.
Okay,
Here we are.
Yeah. So it's this, except over 3 days, all days. I don't know if this was enough. Don't come to that. But it's this, except all the stuff that we couldn't cover.
Nice, nice, very good. So yeah, by all means, sign up for the Neary News. Become a Neary sponsor. You see some of the details here. You can call Diane Langelier at the Neary office. Here are our sponsors, again, from all over the United States and perhaps beyond. I see some names that I actually honestly don't recognize. And some people, what you might not know from looking at this list is that some of these folks, some of these are actually private practices. I believe Yarek Counseling is a single provider, and a really good guy with whom I've exchanged a few emails over time. So Phil, I think we did it. This has been a fantastic 3 weeks. It's great to go back and listen to how you think about these things. And so on behalf of everyone, I just want to say a great big thank you, Phil, and nice work and rock on.